Today, we're going to be presenting the online webinar on NEMSIS efforts to support mobile integrated healthcare, community paramedicine documentation. We're excited to have Kevin Nicholes giving the presentation today, where the presentation is going to provide a detailed overview of the updates the NEMSIS team is working on to support mobile integrated healthcare, or MIH, and community paramedicine documentation. From here, I will make sure everyone is in the room. I think we've got everyone in here, Kevin. So if you're ready to go ahead and take it away.
Awesome. Thanks, Chris. I need you to start working on some skywriting though. That'd be the next
Sky,
social media skywriting. We'll just start, no, and also for our weather report, it's gonna be a, cool high of 84 here in Austin today. I'm pretty sure Sundowners probably got me beat down in Houston. But anyway, so today we've got a lot of material to cover in a short amount of time. So the initial section, I'm gonna go kind of quick. So NEMSIS is going to we're going to cover what we've done so far. And my prequel statement is that this is an active work in progress. If you attended our summit in Tampa about a month ago, you notice that this is different than what we presented to Atrium last week. And the next iterations will probably be different because we're going to take a lot of input from you guys. There'll be an opportunity for you to fill out surveys and comment on every single element and everything. And we read all of those comments and we institute those to try to hone this in. So a little backstory about me and my personal regard for the MIHCP program. When I was a field provider for 10 to 13 years in a large urban department in Central Texas. And my last several years were in the MIH program. And so I got to see a lot the impact of that. And I got to be a part of a team that helped grow that. And so I really find this subject to be important in the future of EMS. I think I heard a quote last year at EMS World, and I've shared this before. MIH consists the quote was MIH consists of 4% of EMS call volumes. And I disagree with that statement. I think it's 4% that we know about. And so one of our goals here at NEMSIS is to try to eliminate that. So let's just jump right in. Uh, there we go. So when we first think about community paramedicine, mobile integrated health, and for right now, I'm going to use that term to speak to, as a whole. I know there's a lot of discussion involved. Well, what is community paramedicine? How is it different than MIH? But for this webinar and this presentation, essentially we're going to be referring to both of them the same. And I don't want to misconstrue the fact that they are different, but there are some similarities. So I think about oftentimes how did an agency get an MIH program? I know for where I worked previously, it was because they realized there was a need in the community. And at that time, it was a high utilizer. And so they realized that there were unmet needs for those patients that caused them to use 911 as a primary care. A lot of agencies potentially got grant money for the opioid epidemic. Maybe they had falls or something where they identified a single need. And from that, the MIHCP providers are an incredible resource and they're able to have become a solution and find a solution that it quickly expanded. I often think of MIHCP as a hub and spoke model where it just continues to grow and branch out and branch out and branch out. So some of the struggles with that MIH, how do you define it? What is it? How do we measure it? And more importantly, how do we fund it? And so some of the things that we feel like NEMSIS brings to that is we have that experience working with those stakeholders, both internal, external, across the map. We understand the importance of a core data set. That's what NEMSIS is based off. The NEMSIS data set is a core data set for EMS documentation. And we're also really familiar with the different agency types, whether it's for-profit, nonprofit, third service, EMS agency, fire-based, hospital-based, aeromedical. We really understand all of those. And so thinking through that, we kind of came up with some goals for this MIH CP data set. We want to prevent the duplication of data entry. I know when I left the MIH program that I was in, I distinctly remember at one point searching through a 172-page Word document for a patient's interaction record looking for one line. And that's just not sustainable, right? Like it's a lot of work. People are documenting things in Excel spreadsheets. They're documenting things on a EPCR. They're documenting things on a non-NEMSIS data set. There's this wide version, like there's a wide um, spread of ways that we're documenting it. So we're trying to decrease that duplication. I know my previous role or my previous world in MIH, I had to document something 4 different times for the same interaction because we had to have it in this record and that record. And maybe we needed a social worker record over here so they can reference it, but they couldn't see our system. We needed an EPCR over here so we could bill for it and vice versa. Um, and so we want to decrease that. We also want to understand what's an essential data elements for operational, clinical, and administrative. We don't want to reinvent the wheel. We don't want to create. If you look at NEMSIS, NEMSIS is massive, this massive data set, and if we were to try to do that in the first run with CPMIH, we would fail miserably. So we're trying to find out what's that core base, those essential data elements. We want to help use those elements to help influence policy and procedures at the local, state, and federal levels. And also, like when we talk about MIH CP, it's really hard to bring up payers and billing because so much of what MIH CP is about finding that need with those and like giving to them. But we have to keep the lights on, right? Like we want to get you reimbursed. We want to make it streamlined so that payers can streamline it. It's better speed, and so that we can help fund those things. And also, one thing to notice, and we'll cover this again later, NEMSIS is a event-based documentation system, and we want to be able to take those event-based documentation activations and help them line up with a longitudinal data collection. So as we're working through this, we have reached out to countless number of agencies, both like federal, state, local, different organizations. This is just a minimum, a small group sample size of what we've talked to. NAMI-HP, NASIMSO, USFA, CMS, HHS, our NEMSIS software vendors, and then also along with the non-NEMSIS software vendors. We will, and those include companies like Julata, Health Call, Rainbow Health, and there's many more, including also Epic, Cerners. We've also talked with legal subject matter experts, agency administrators, and the one that we're most proud of is that we are continuing to look for the clinicians because we need their input. They're the ones putting that data entry in. We need to make sure what makes sense to them. So let's talk about real quick why we want a data set. So I'm assuming everyone on this call, if you're in this call, you have an understanding of what NEMSIS is, but I want to kind of touch base on this real quick. NEMSIS is the data standard for EMS documentation and data collection. So I think I heard it best one time that we are the Webster's Dictionary of EMS data. And as riveting as that sounds, that really is what we are. And so for those who don't know, there are multiple levels of data. At the blue plate, I will call it a plate. I don't really know what else that would be. Column. Anyway, the blue column, that's all the elements. It's over 600 elements. It's all the potential elements that we could have that are part of the NEMSIS data standard. Within that, your local agency will select a smaller set. It'd say, we want to collect this, this, and this. There are a smaller set typically than your local agency's data set is. The state has requirements on, hey, as a state, this is what's important to the state. These are the things that you're required to collect. And with even smaller data set is that NEMSIS that national data set, the national elements. And how we get that data is you will fill out an EPCR. The software agency converts that into an XML structure. That XML document is sent to the state database, and then the state forwards that onto the national repository. The fastest record we've had, and I believe we should probably run this number. We could probably beat it, but 7 minutes is the fastest that we know about. And I believe we have run about 90% of having all records within 3 days. So 3.5.1 is coming out, as well. I think majority of the people in this call are aware. 3.7 3.7. I don't know where that came from. 3.5.1 is about to be rolled out. Everyone's in 3.5.0. So without this data set, you can already start documenting CPMIH calls in version 3.5.1 by selecting the type of service requested is a mobile integrated health uh, encounter under eResponse 05. So that's one way that we can at least start that process. Because one of the challenges we have is if you wanted to know how many cardiac arrest calls there were in the nation, we can give you a number. If you want to know how many intubations there were in the nation, we can give you a number. Yes, there are some caveats, there's some adjustments and things like that. But as a majority, we have an aggregated data set that lawmakers and decision makers and funders and billers can look at and say, okay, is this important? But if you wanted to know in the state of Texas, I reside in Texas, I worked MIH in Texas. In the state of Texas, how many MIH calls did you have? We don't know. In the county I worked for, how many MIH calls do we have? We would even struggle to get that number because we had that like quadruple duplicate data duplication, documentation duplication, et cetera, right? So we don't really know. And so if our goal is to get an aggregated number. So this is that first step. So we can at least say, hey, how many MIH calls were there last year? And maybe we could see if that 4% number is correct or not. Two other ways you'll be able to document within 3.5.1 and e-procedures 10, e-medications 10, which is the role of the person performing the procedure and the role of the person administering the medication. There is a community paramedicine role. So that's at least a very initial step in which we can start that documentation process. Some other things that are potentially available. So there are custom elements, and custom elements are where a local agency or a state will reach out to their vendor and say, "Hey, we want to collect this information." Let's say that you want to know the patient's eye color. That's incredibly important to your state. You can reach out to your vendor and say, "Hey, create us a way in which we can collect that." The challenge with custom elements is that those elements are then isolated to that one incident. We can have national custom elements, which are the same thing where they are customized elements, but they are agreed on at the national level across the board. However, they're not captured in the aggregate form. And so typically with national custom elements, we develop them, and then the next step will be most likely they'll be included in the next version. So right now, we're kind of at this crossroad point. What do we do with this MIHCP data set? Are we going to create as a module based data set where it's just a small, separate, isolated data set, or are we going to include it as part of the national standard? We're not really sure yet. We're still having those discussions. Our first step is to identify that small group of elements. So as we move forward, we're getting really close to the survey. If you have thoughts and opinions on that, please put that in our survey. So what's not going to be captured is we're not going to capture assessment scores. We're not going to capture overall outcomes and things like that. Because if you think about assessment scores in the MIHCP world, if you said do a fall assessment, I mean, just incredible amount. Think about the Gravity Project. The Gravity Project is a nice resource. So you can go and it's basically like essentially a dumping ground of MIHCP things where if it exists as an assessment, they can include it. So it's a fantastic resource if you're getting started, but man, they have they have 10 different versions of fall assessments. And so we're not gonna capture that. There are better ways to capture that. And we don't need that at the core NEMSIS, the core MIHCP data set yet. And the challenge that we're really facing is NEMSIS is a event-based documentation. It was designed for 911 EMS response and later incorporated interfacility transfers, which is still an event-based system. MIHCP is quickly a longitudinal patient record where majority of the patient population has multiple interactions with that crew. I believe it was the Jonathan Flight of Beyond Lucid that made a comment that what he felt the difference between MIH and non-MIH calls are, do you know the patient before you get there? And I think that's really important. So that's one of the challenges. And so that's why we're saying if we can create that core data set that can talk to and work with those event-based systems. So as we're going through this, think about what core items are we missing today? So we got a lot of questions. Why create it? we need to standardize data collection. I know vendors, there's 14,000 agencies in the United States, and so we don't want to have 14,000 different ways of documenting an MIHCP call because then we won't be able to get to we won't be able to compare apples to apples. We'll be comparing apples to pineapples and oranges, etc. So we want to make sure we want to standardize that collection, and we want to create with that standardization we can create a clean data sharing between vendors and stakeholders and vendor to vendor, etc. So we really think about this chart. Low accuracy, low precision is that one off where you're building a one off system for everybody. You're not really collecting the same thing. You can't compare anything. You don't know if you're missing the target or what. And whereas if we move to the right, we have low accuracy but high precision. That low accuracy means we're collecting eye color when we really should be collecting something else. And not to say that eye color is bad. If you have a research paper about eye color, send it my way. But you're all collecting the same information, but it's not relevant. Whereas if we go to that high accuracy, low precision, we're kind of close, but we're still kind of all over the board. The goal is to get that small core data set that's highly accurate and highly precise so that we can use it. And like I mentioned, here are some different ways that we've heard that individuals are documenting their MIHCP, um, their events. And, free text. I've even seen people that fill out a paper form and they take a picture of it and they have a file on a computer that just has a bunch of pictures of forms. So, I mean, it's all over the board. So we're trying to really streamline that. We want to standardize the data for that high precision, high accuracy so that we can analyze it. We can understand at an aggregate level, at a large scale, what's the impact. And that way, you as the providers and the states and vendors can say, hey, this is really important. And we can take that and then we can start saying, hey, this is how we can get grant money can be established for it. Payers can have an understanding. And we ultimately want to reduce costs as well. Um, NEMSIS, we're doing this in the same format that we do with all of our data things. We reach out to our stakeholders, we collect what the information. Gen Korea has this probably 1,000 row at least document of spreadsheet of every element that someone said that they collect that's important to them, and we've essentially sorted it, grouped it, and we're saying, okay, what's the most important? What is most frequently being asked? So from that, you can start with custom elements while we're still trying to figure out either an MIH module, is it part of the data standard, etc. All right, so we're going to jump into our data dictionary. So this is just an overview on how to read it. The vendors and state managers who've been a part of the program for a minute will understand this, but for everyone else, just to kind of give you an understanding, there'll be an element number, which is simply like that response 05. It's so we can keep catalog and identify. Then there'll be a common text language element name, which will say, role of person administering medication, etc. We'll have a definition of that. And then the data type, whether it's numbers, words, etc. And then for those that don't know, a recurrence simply means how often can you have that within your data set. So if the number on the left is a 0, that means you don't, it's not required. You don't have to have it. And if the number on the right is a 1, that means you can only have the maximum one time. If it's an M, that means multiple. So you can have a lot of them. And so if it's 1-to-1, it means you have to have it and it can only occur one time. Where if it's a 1-to-many, you have to have it and it can have a bunch of them. And then also our usage is some things that we'll talk about, not values, etc. Again, these are not set in stone. This has gone through multiple iterations. If you attended the summit in Tampa, this will look similar but very different. If you attended Atrium last week, it's going to look pretty similar because I just got home on Friday and I haven't had a lot of time to take that survey results. But in future presentations, you'll see that we continue to whittle it down. So this is a survey. This is how the survey is going to look. We're going to have two different surveys. One is going to be specifically to the data dictionary, and the other one's going to be to a line of service. This QR code is going to exist on every single slide. And I need to check with Randall Emmerman made this, and so I need to check with him when this one closes, but it won't be for a week or two at least. So you'll have time to, if you want to just listen and then time to chew on it later, or if you want to jump right in. So without further ado, so our first element, CPMIH01, it's simply be a patient identifier. This is going to be a string this is something that we can identify that patient. So think of it as like a social security number. It's not necessarily going to be your social, but think of it that only, in theory, only, a person only has one social security number. So that is kind of what this is going to be. And if you really have a question, I really want to spark a conversation, put something in the chat. We can discuss it, but we do have a lot of slides to get through in a small amount of time. So most likely what'll happen is I'm just going to power through these really quickly, leave some time then for conversation. So, um, okay. CPMIHO2. This is the best time to call the patient. So, I'm sorry, best day to call the patient. So, like Monday through Sunday, non optical, not recorded. So, this is going to be simply, hey, if you want to follow up with this patient, when are they available? What's the best day of the week to contact them? Best time of the day, morning, afternoon, evening. Uh, and so that these first couple kind of work together, and then we're going to say alter what's an alternate contact type, whether it is a case manager. That's a change that came from the time we met in Tampa. Whether it's going to be a friend, etc., power of attorney. So really, like, who's an alternate person that we can get a hold of? What's the name of that person? And then what's a phone number for them? And that data type is simply a regular expression to allow for the software to read that phone number. And I'm more than, and I know individuals, if you're trying to take screenshots or anything like that, you don't, I mean, you can if you want, but just let me know and I'll send you guys a PDF of this. We're very transparent with the only caveat of none of this is set in stone. This is just the update to where we are. So, and also the video will be posted on our YouTube channel in about a weekish. I don't, Chris will be able to tell us exactly when, but just look for that. Okay, so then we have CPMIH07 is the referring physician type. And so this is kind of what is the role of that physician that is referring that patient, if it's a physician. And that's a comment that we had last week was it might not be a physician doing the referral. There are some rural areas that maybe they run a physician assistant. So we need to evaluate, does this need to be a referring clinician or a version of that? So those are some things that we've heard, and so we're working through those. Referring physician name, and again, if we change that previous '07 to a clinician or a different name, we would change this as well. But this is that name. And I just realized that there's an error here. We have the definition says the phone number. It should say the physician's name for the program. So I apologize about that. And then here's the phone number that we would put in for that referring physician if you need to call and discuss the patient with them, get records, etc. And then now we also have a primary care physician name, and this is who the patient's primary care physician is. And then we also have the primary care physician phone number. And then we also have a referral case number. And this is something we've heard a lot of from individuals saying that they would like a case number because potentially within, like, internally they use they have a case number, or the physician, the referral service, maybe they have an agreement with a service where they constantly make referrals, etc. And so that number would be, it's a string, or you could put a number that they could reference. You could reference however your agency needs that to work. The visit number. So the idea with this one is that an individual agency meets with John Doe, and this is more important for what we heard last week was this number is more important for potentially like for-profit type agencies, or potentially you received a deal with not a deal, but you've received like a grant or something from an insurance company where it says, hey, you can do 10 diabetic follow-up calls with this patient. So what you would enter here is every time you interact with this patient, your first visit would be number 1, number 9, number 10. And so the idea is so you could see, okay, this is the 10th visit. I need to go back and get additional funding or however that works. And we've heard like if you work for a municipal or county-based nonprofit type, this isn't as important. But we've heard this number a lot as they want to be able to track that. And this is that challenge of NEMSIS. Excuse me. NEMSIS is not a longitudinal system. So this is kind of our way of putting a band-aid on that. My little Disney on Ice cup my kids picked out for me this morning. All right. So now we have the stage of the visit. So what stage of this is this visit? Is this your first visit with the patient? Is this a continuing visit? Is this a graduation, readmission, closeout, etc.? So this is a how like where are you in that stage with that individual patient? Referral source. This is how did that patient become within our system? And so we've been told there's been several more that we could use that we received in Atrium last week. And so we'll expand that list. So if you think of others, please add that to our survey. Additional recommended services for the patient. And so we want to, okay, let me first explain this one. This one is, are there things that you notice maybe when you're out to do initial interaction with the patient, you look in the fridge, you're like, oh man, they don't have any food. They need food service, or maybe they don't have power, so there's some sort of like power like housing need, or maybe they need help getting insurance, whether that is a local I'm blanking out. We had a county funded service, insurance service, maybe getting into that, and then or maybe they need some DME or something like that. And so one thing that was brought to our attention is we need to potentially split this up into, namely, the housing services is, or we need to split housing services too because housing service to others sounded confusing because are we trying to help someone get housed? Maybe they're unhoused, or are we do they need help? Maybe they're wheelchair bound and they have a stair to get out of their front door. So do we need to find them a service to help with their housing repairs, etc. So that's one thing we're looking at that was put in our survey is splitting those two up. So if you have any other ideas or any thoughts on this one, please put that in your survey. Were you called to assist law enforcement? Was law enforcement called to assist you? Those are two things that came up a lot. And then we are external report numbers. So if you have all these different things, you have a registry ID of a registry ID number of some form. Um, maybe it's a organization you work with. I know we worked with a lot of social working organizations or nonprofit housing repair services, and they had an individual number for their case, so to speak, or their report. We would put that number here. This would be a one to many, so you're able to put a lot of these, excuse me, these numbers in. Uh, I'm sorry, this is the type. I apologize. This is the report type, and here is where. Okay, well, I just found another. We need to change this to field values to. We need to either split this or change that. All right. Anyway, so we're gonna have a second number. This is a report type and then a report number. So, and this will be one to many. So, like I said, this is a complete work in progress. Then we're gonna have factors that influence your health status. So our Z code, the ICD-10 Z codes that will influence your health. Also, we want the date of your most recent healthcare visit, whether that is with your primary care, ER, etc. What's your most recent one? It is not going to be a required element because I know that was a question as well. What's the reason you had that healthcare visit? What's the name of that provider in case you need to follow up with them? And what's the phone number associated with that individual? This is one that's changed several times as well. through iterations, and at this point, it is: has the patient served in the U.S. military? Yes, no, not applicable. And is the patient eligible for VA benefits services? All right, so that was the data dictionary. That's it. 28 elements. That's what our goal is, with the caveat there might be one or two more because we're going to split some things up. Um, this was like an example of that. This was U.S. military. Um, this was originally, I think this originally says, were they honorably discharged from the military? And through that discussion in Tampa, we realized that um, there is not a, like, even if you were discharged, dishonorably discharged, you're still eligible to receive some VA benefits. And also, if we asked, were you honorably discharged, we would lose a lot of, I want to say, street cred, but that's not, that was the term that was used in Tampa, but I'm struggling to find a better term. But anyway, we would hurt that relationship with that patient. So now we're simply saying, did you serve in the military? Are you eligible for VA benefits? We don't ask whether you're honorably, dishonorably discharged. So that's an example of how the survey results have helped us create a better version. If we're not, if this isn't better, and we need to eliminate the military one, then we can just put that in your survey. So again, as a refresher, here is the survey for the draft data dictionary. And what you'll see every on the um, on the survey, we'll have the slide right above it, just like this. So you'll be able to reference that. There is one where we talk about report types. We changed it from a zero. It's on the survey to be listed as 0 to 1. We changed that to a 0 to many. So, but if you, any point you disagree with any of these things, please put on there. As our vendors and our state managers know, we have really thick skin. This is the best way for us to try to hone the product to be the best product for everyone to use. Okay, so now we're going to talk about line of service, and this term is something that was we kind of came up with it because we couldn't come up with a better term. This essentially is what the intervention that you're doing when you have the MIH visit. So if there's a better term for us to use, let us know. Um, this is going to be a survey as well. So this QR code refers to this one only. The line of service survey. So one of the things that we did when we went to Tampa, we presented this. We had uh probably we had a lot. We had a lot of elements that were the type of care performed. And so one thing that was a resounding theme that we heard is we could really clump those together in types of service performed. So that's community event. And one thing we heard in Atrium is community event maybe not isn't the right term because that might be confusing with like a disaster event or something. So, but anyway, community event, chronic care, focus care, marital, prenatal, mental, behavioral health. So those are going to be some groupings. Uh, and so then we'll have the next element will be what's the reason. So basically, you're going to pick from a pick list, and it's really a long list. And so here's a list. You can see that this is a list we come up with. It is really long. And so initially we almost had an element for every one of these. And so I think what we're going to do, we scaled that back. So now that this would essentially be a drop down of what is going on and happening. And it's for those that are having trouble visualizing this, and software vendors, just bear with me. The last time we presented this was for individuals who don't use that aren't working in an EPCR system. So for them, they don't have that understanding of how that works. So one thing that we built, well, here we'll cover this first. So here's that nesting view. So if you selected marital, premarital, marital, maternal, prenatal, two options to pop up: fetal monitoring, OB, newborn wellness. And we're not married to these elements. We can always change, add, decrease. And so what we're kind of working with is if you are on an EPCR platform, essentially you tap a button. So if you did community event, you tap that button, and then the drop down menu of 4 different elements will pop up. Same thing with the maternal, prenatal; those two elements will pop up. So I want to please take a minute to kind of look over this. This value list will be in that survey. So please let us know. I know that we have also have been informed that there's some different terminology that would be better. So as you're going through that, help us out in the sense of a lot of times terms change really rapidly. So as software vendors, state data managers, you guys understand the workload that goes into change a term. So if you guys can help us come up with terminology that will stand the test of time for a little bit longer, that would be really helpful as well. So here's that QR code one more last time. And again, you will have the table will be in on the survey so that you'll be able to answer the in comments. So I'm gonna kind of start wrap it up here, and then we'll have some questions. And I know there's some comments in the chat. So our ultimate goal by August of 2025, it's coming up really quickly. Our ultimate goal is to identify that core set of elements. We're not saying that this data set will not be in service in October 25, but we want to have that core data set, those 28 elements, 27 elements, 29 elements, whatever it turns out to be. We want those to be identified. And we also are going to discuss those and work with those and look at it. We want to be able to present those elements at our annual meeting in front of all our stakeholders where we can essentially say, yes, we agree with it. No, we don't agree with that, etc. The goal will be that those will be in the next NEMSIS data set, whether that is a module based, a part of the complete data set. We're still going to work through all those details. But by August, we want to have that core elements established. At this time, our goal is to have all of these elements at the national level. And so we want to see what we'll be discussing potentially at our meeting and moving forward as well as, and you could put this in any survey results, is there a reason against having these elements at a national level? So for those that want to be involved, again, I think my personal belief system is that this is the MIHCP is the single greatest impact to the EMS field since the white papers, because EMS is constantly the net that catches everything that falls through the cracks, and more individuals are relying on that. And the great work that EMS agencies, states are doing, vendors are doing, is simply shining light on that. And so more and more healthcare systems are realizing like, hey, EMS is this untapped potential. So I'm really passionate about this topic. And if you have that passion too, you want to be involved, some things that you could do. We are, so we send out emails looking for input. We have a working group that Jen has, and the first email, one of the first or second email of like spreadsheets and things have already been sent out, and we're going to continue as these iterations go, involve them. So if you want to be a part of that, there's an opportunity for that. And then every conference that we attend, we try to get this on the agenda so that we can present our latest iteration and get feedback. If you're interested in participating, you can reach out to myself. You can reach out to Jen or Randall, as well as fill out a help desk ticket and just say, hey, I want to be part of that team, and we'll help route you there. So at this point, as you fill out the surveys and put comments in the chat, are there things that we missed? Are there things that we could do better? Are there things that we're way off base? And before I start calling on people, I don't have all the answers. I might have to say, that's a great point. Let's write that down and we'll get back to you. Chris, are we good people are good to, before I call on people, I'm going to go through the chat. Looks like, okay, yep, Monet answered that. This will be posted, and if you want the PowerPoint, just let me know. Lauren, yep, right on. I'm glad I answered that question for you. And Jennifer from USFA said, would you mind repeating the organizations involved in the project development? Yep. So NAMI-HP, National Association of Mobile Integrated Health Professionals, have been active. Let me just go back real quick. And this is only a basic list. We've dealt with a lot of individual agencies. The Center for Medicare, HHS. Okay. So Sundowner suggestion for the external report type, add one more field, external report provider, call sign unit. Okay. I can get behind that if it's so you're saying that my assumption is, you can tell me if I'm right. I did it all the time previously when we tracked it. We wanted to see what units in our own system were our champions, and also what units weren't champions, so we can say, hey, why do you keep, like, where are we getting the most referrals, maybe by district, etc. You talk in individual units within your system. So that's interesting. So if you would please put that in the survey. Um, Michelle says, "Be great to hear how EMS data sets could be tied to the MIH CP data set and the software itself. For example, if there could be a data field that auto-populates last state EMS." Okay, that's an interesting one. Last state EMS incident occurred for the patient in the MIH CP data set. So I would say that that would be, and vendors can feel free to string me up, but I would say that that would be something from that your vendor could potentially help build. And one other thing too to note about this MIHCP data set is that we didn't include patient name, demographics, because this being a NEMSIS record, all of those will interact. So Michelle, that's a great example. Okay, someone asked for the Jay Guthrie asked for the PowerPoint. Mike asked for it. Given, and then I promise Ann, I'm gonna call on you in a second. And given that many agencies include CPMIH in the CRR activities and large percentage delivered via fire-based. We are an active. Forgive me, I don't know what CRR is. If someone could type that in, so I can ensure that I'm not missing it. But we're in active discussions with Nearest and USFA about a community risk reduction. Perfect, thank you. About some coordination between the data sets. Ann, what you got?
Okay, so mine is probably just that I lost track of certain things as we went through, but it sounds like it's a separate data set, but it ties into the NEMSIS data set. Will it be submitted as part of the EPCR so that those are together? You're going to have a combining ID? Is that kind of the idea?
Yeah, that's the idea. It'd be that patient, that very first element would be the patient ID. And so those would be
Right.
combined. As far as like if it's submitted by the NEMSIS data set or not, those are the things that we're still working through.
Okay,
But
because I know
that,
like we have something in our state called treat and refer. I know Ben Fisher's on the call, and he used to work with us, so he knows what that is, but it's a little bit different. But right now I know agencies have like different softwares that are completely unrelated to their EPCR product, perhaps through a same vendor, but I don't, yeah, you're right. There's no standardization. So I'm kind of trying to figure out how all these agencies that have different products from before where they've recorded their data, is there, kind of like a plan for how this is all going to tie together? Does that make sense? Because they're going
yes.
to have all of this. Okay.
Yep. The plan is, as far as that, we're trying to figure it out. I can't say what the exact scenario is, but the idea is that these would all tie together so that you can include that. I know what else do we have? What other questions do we have?
Sorry, I have one more related to that. Sorry.
Yeah, no
Um,
worries. Let me get to before I miss it.
oh, sorry.
The sheer there is a that is a excellent comment he made. There's a comment about, is there an element to track if the visit is in person, telehealth, or virtual? That is something that we heard loud and clear at Atrium last week, and so we will please put that on the survey in case someone else didn't, so we don't lose track of that. But we heard that is I was unaware of how big of a deal that made it for everything else. So we are absolutely going to have that if it's an in-person telehealth, etc. Sorry, Ann, go ahead.
And I was just thinking like there probably will be companies that have mobile integrated health software that incorporate these data elements down the road, and perhaps they don't do EPCRs also. Um, so is there going to be a
As
separate compliance process, or have you
so
guys?
we're still working through all that. We're and that's one of the things that we're gonna be involved with the DMC and working through those things of what does that look like? Because some states require, if you submit to the state, you have to go through a compliance process. What does that compliance process look? We're working through all of those, and those are active conversations right now, because we do work with we have been in discussions with those non-NEMSIS softwares, the Rainbow Health, Shulatas, and they're just as excited. And the health calls, they're just as excited about this core element set because they want to create those HL7 pathways and the sharing of data back and forth. And so there will be a form of compliance for that. Now, whether or not that has to be a 100% NEMSIS compliant, where the EPCR, I don't, and this is where I want to make this clear. This is my speculation and kind of where we're kind of leaning. This isn't set in stone, but I don't think it's going to be a complete NEMSIS EPCR style compliance, but there will be a form of compliance to ensure that some of those are met, that information is compliant and met and accurate and valid and all of those things.
Okay, yeah, because as a state, we kind of rely on you guys. We don't have an extra compliance process, and so we just kind
Yeah.
of say if you're a NEMSIS compliant vendor, it's because
Yep.
we say it has to be in a certain format in our rules. It's just how it works. So I wanted to make sure that if we ended up participating, that we could still kind of refer to that potentially. Thank you.
Yep. Yep. No, we're on the same page. It's just as far as the details and how that exactly looks, we're still working through those. Who else? Anyone else? Looks like I got the last of the chat. Any other questions? What else can we do? Sure, Chad, we can talk offline. That's fine. Oh, yep. So, what else can we, what else can I answer?
Thank you, Kevin.
Absolutely. Do we, to kind of, since we have a little time, we have about 11 minutes left in our allotment, but I'll stay here until I can answer anyone's questions. Does anyone think we're way off base? Does anyone think we're off the reservation? Are people happy with the direction, knowing that there's still modifications and work to be done? Or is there anyone that thinks that we're missing something pretty blatant? I'm just trying to facilitate conversation here. So, does anyone have anything for me in that regard? So what I'm hearing is we're perfect and it's done. There's no room to improve. Yeah? I'm much better at in-person interactions. So thank you, Jennifer. Yeah, it's a great point. Jay Guthrie said, I it's a good start. Everything needs to evolve with time. And Nemesis is I'm new to Nemesis. So this is I'm no longer the token new guy, but I'm close enough. But it's been around for 25 years and it's evolved. I think the first data set was, and I'm sure there's someone who can correct me, but 40 elements, 20 to 40 elements, and it's grown significantly and evolved. So, um, and I think that is something that we constantly remind ourselves that MIH is growing at a much more rapid pace than EMS did during that time frame. But we want to make sure that we are still like eating the elephant one bite at a room. Shri, you said, how about a referral out? Are you referring? I think let me summarize. You can tell me if I'm right. We've heard something as well as you've dealt with the patient, you've helped meet their need, and now you need a way to um, get them out of the bridge program that is the community health paramedicine and into more of a long-term solution. Is that, am I?
Yes, and also if there are no service that can help that patient and they have to refer him out into a different program
Okay.
outside the MIH program.
Okay. That's a that's a great that's a great point. I know the system I worked in, they were fantastic, and I'm gonna toot my own horn. We were great at meeting the patient's need. Everything from like you could pick up the phone, call 911 for your toothache, and we could all but bring a dentist to you. The next challenge they have is the next challenge that you have is how do you get that patient might then become reliant on your immediate needs. How do you transition them from bridge to that long-term care? So uh, I would be interested if you would please put in the survey some how you think that we could incorporate that. How can you incorporate that into an element? If it's just simply like name of the person you referred to, so that would be really helpful. Let's see. Any Jennifer, I would like to could you expand on that thoughts of including public health element? You don't have you can just put it in the chat if you don't want to speak publicly or put in your
Yeah,
survey, but yeah, go ahead.
no, I'm here. I just know that some public health departments are, offering resources and tracking, drop-offs of naloxone,
Yeah,
keeping
leave behind
track
the
of those
Knoxville.
things. And sometimes, fire departments, EMS agencies are partnering with them. So as you had a data element for did law enforcement call you, or did you call for law enforcement? Just adding that piece in there. Was
Okay.
there any association with public health, local public health?
We kind of had some we were kind of trying to figure out if that would go under this additional recommended services, but I could see where like a public health type. That's a good point, and we'll have to think about that. Did we does this will this be covered in that, or do we need to have something separate? Um, so that's a good point. I appreciate that input. Anything else? And again, we really appreciate the dialogue. We appreciate the time. If you were to put time in on these surveys, it really does help hone it. And we have had some people that attended both the summit in Tampa and then our atrium presentation last week, and they were happy and impressed with the changes that we made. So I think that really speaks to the credibility of not only NEMSIS but the program that you guys have helped build, vendors, states, agencies. You guys have really helped build that environment of fostered collaboration. So we really appreciate that. As an extension of EUPROS type of MI, is there any element? Yes. So there was sort of the question is an extension to eResponse 05. Let me go back to these. eResponse 05, you can in 3.5.1, that's not part of this data set we're talking about. This is what's already in place. As soon as you adopt your agency and state adopt 3.5.1, you'll be able to document as a call response type of service requested was mobile integrated healthcare encounter. And then an e-procedures 10 and e-procedures, medications 10 regarding the role of the individual. You can establish their role as community paramedicine.
But how about the type of service they are providing on that particular visit?
The only element that we have right now is the 3 eResponse 05. And
But are you planning to include a custom element for capturing that? That's what I meant, extension to eResponse 05. It is MIH surveys, but is it immunization or fall prevention assessment or
correct.
what
I
type of
understand what you're saying. As a there's potential that we could do custom elements like that, but right now that's really why we're focusing on this data set will be that extension that captures what occurs. Oh, and everyone, we have 3 minutes left, so like I said, I'm gonna stay on until everyone has a chance to get their question answered. I appreciate you guys attending, and then if anything we missed, email me, Jen, Randall, fill out a help desk ticket, do the skywriting like I'm getting Chris to do, and then we'll have this video posted. And what else can I answer for you?
I guess I'm trying to envision as a state from our role, if we collect this data and if we send it on kind of through our existing system, if it takes on this as an additional kind of module, it would be part of the EPCR, I think, in some ways. And I noticed like you had the e-response 05 is modified, but there's those other mandatory elements for NEMSIS that you can't send something, it will fail without it. And I don't know, are you planning on adjusting those so that they can be used, so that we can send something, or it will somehow have some kind of different tag to it so that it doesn't have to go through those additional.
Yeah, so that's one of the big questions that we're still actively working on, is how do we do that? Because right now, in theory, and I'm speaking as my non-provider is like, oh, well, you just fill out all those details, and I'm sure they get a blood pressure every single time they talk to the patient, regardless of what it is. But then I put on my clinician hat and I'm like, oh man, if I'm just dropping something off, I'm not doing an assessment. What does that look like? If I'm just doing a fall assessment, etc. So how do we, does this, if we make this all part of the NEMSIS data set, do we start creating like fails and errors that look at, well, if this vital signs are not like part of the, you don't get vital signs if you don't take, if you fill out one of these elements, can you not do vital signs, etc. So those are absolutely conversations we're having on how do we make that work. And that's the big challenge with a event-based documentation system, is because we need to put in the patient's name every single time. Now, I know some vendors have ways that you can search for, I believe they call them like known patients or previous patients and things like that. And but those, even then, that's sticky because you rely on spelling and socials and things like that. So we're still trying to figure out. Do you have any ideas on how we could make that work?
No, I don't. I was more
Okay.
thinking things like the mandatory elements, like
Mhm.
response mode to scene, or
Yep.
I mean, right now, if you don't, like, I don't know if you would consider an MIH patient truly a patient. And then if they tried to document e-disposition 27, does that have a modified value added to it? I realize this is stuff for down the road, but I'm always thinking like this because
No,
I
and
get
those
these
are,
warnings saying my stuff has failed because I had an agency that didn't fill something out that was mandatory. And
yeah, absolutely. And those are for sure things that we think about. It is down the road, but that's things that we need to think about as we get, we can't just walk down the road and see where it goes. We kind of plan our route a little bit.
because I kind of
Um,
doubt a lot of states have separate CP collection software right now. Maybe somebody does. I don't
mhm.
know of anybody who does. And a lot of states probably aren't going to be up for purchasing a completely separate system to send this data. So then I'm trying to think about,
Yeah.
if we do it in our existing system, we would have to send it through the way that software already does, and just, I know
Mhm.
I'm getting ahead of myself a little bit, but this stuff usually has to get
Yeah.
planted years anyway. So yeah.
Yeah, and you're absolutely right. And so that's why we're trying that, and that's our implementation is going to be one of the big, I think our first big hurdle was first identifying what's important to people. What's the most important things? What's that core group that we can collect? Our next hurdle will be that implementation of how do we get everything to talk together. And I think we're also going to rely heavily on vendors too to help us understand, are there ways that we can tie these things together. But yeah, we're absolutely thinking about that. Maybe there's like Steve said, a new e-disposition option potentially, right? Like those, the big takeaway is nothing's off the table, right? Like this is MIH is all about having creative solutions to everyday problems. And so we're nothing is off the table, and we're willing to entertain any ideas. I'm looking at you, Lauren from Zoll. Just kidding.
This is really exciting because I know like I mean, I don't know if it would apply for this, and we don't have a lot to do with this at the state level either right now because it's such a weird way to collect data, and it's not a way that we can really standardly do. But I know like some places in our state are looking to see if people who go on lift assists, which are almost impossible to collect clearly in our system, end up leading to people, usually elderly people, that end up having a severe fall later, and are those what is called prefacted? I can't think of the word. By all of these little lift assists that aren't really getting
Mm-hmm.
documented. And is there a huge way in public health that we can intervene before you have these catastrophic injuries?
Yep.
And I think
Sentinel
this would
events.
be a way to do it. Yeah.
Yeah, I mean, I know I personally, and I've talked to some other individuals on our team that they get a little twitch whenever they hear the word just a lift assist, because we've either, if you're a clinician long enough, a provider long enough, you're either unfortunately the crew that did just a lift assist, and then later the patient within 12 hours had a negative outcome, or you were the crew answering to family members and the patient. Well, the EMS was here 12 hours ago, and they just picked me up and put me back in bed. Why didn't they tell me there's a problem then? So, um, I think these are ways to continue to expand that and identify those needs of our patients.
I also think one thing to consider is if we're adding them to existing NEMSIS elements or things of that nature where they might be hooked into dispositions, that would take a lot of adjustment for state rules. So that would just be one consideration if we didn't go with like a module based.
Yep. Yep, I agree, Lauren. There's definitely it's just like I said earlier, trying to force that longitudinal record into that event-based record is some of the challenges, and we need to establish is that, you know, how do we have that, and because a lot of our thoughts are we create these small groups, and maybe these elements aren't fed directly into the EPCR. Maybe they're fed more. Some of these elements are through like HL7 connections, et cetera, with those MIH software vendors. You know, it's just there's so much of a how do we the ultimate goal for us is, like I said in the beginning, is to quantify that, because if we can quantify the work that MIH CP agencies are doing, then we can help push for reimbursements. We can help push for CMS to recognize that this is a for real deal program. You know, I worked in a program where it was, I mean, the annual budget for that program was like $30 million. It didn't start that way. It started with one person in a former police Crown Vic that they essentially spray painted to try to make it look not like a Crown Vic, like a police Crown Vic, right? And it grew because they were able to justify to their city council members the impact that they're making. Now, think if you can take that and you could put that at the state level, the federal level, man, like you can see like, hey, look at the work that EMS is doing, and then like beyond that's just you call, we haul, that's all. Man, like you could like I think that elevates EMS in a higher elevates EMS to a not just a technician, and then they viewed as clinicians. They're viewed as part of the healthcare family. And Jay Guthrie, yeah, exactly. Justify resources. Anyone else have anything? If you think of anything else, put it in the survey. Shoot me an email. You know, it's conference season, so if you see us at the conference, pull us aside. I know I love talking about this stuff. So I think that's pretty much it. Doesn't sound like there's anything else. Chris, are you still on?
Oh yeah.
Okay.
Hey, big virtual round of applause for Kevin.
Do you have a method in which I can easily share I could share these slides to the individuals that attended this, or is there something that needs to go out through like a MailChimp?
Yeah, we could discuss that. We'll get the names and we'll make sure people who want this get a hold of it. No problem.
Okay, perfect.
Cool.
All right, everybody. I think I'm gonna call it. I appreciate it, and like this is just the end of the conversation right now, but not the end of the overall conversation.
Thank you,
Shameless
Kevin.
plug to come to our annual meeting. We'll discuss this in much more detail.
Perfect. Thank you, Kevin. And also a big round of applause, virtual round of applause for Monet, who puts in all of the hard work to organize these trainings every month. We really appreciate all of her hard work on this. If you have suggestions for things you'd like discussed here during the V3 call or during the annual meeting, please make sure that you put in a ticket and let us know. We're more than happy to consider those for those different forums. Other than that, thank you very much, Kevin, and thanks everybody for coming. Have a great rest of your day.
Thanks, everybody.